Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're going to explore the joys and challenges of working in this incredible field, including topics related to education, advocacy, and leadership. I'm one of your hosts, Megan Doherty, and I'm so excited to have Dr. Max Watson on the show today. Max is a palliative care physician, leader, champion, and pioneer, and he has been an early adopter of Project ECHO, which is an innovative model of online education for healthcare providers. We're at the Clyde Hotel in Albuquerque, New Mexico in the United States, and we're here for a conference together called Meta ECHO. So welcome, Max. Tell us a little bit about how you got into palliative care.
Thanks so much indeed, Megan. I'm an old man and I've been involved in palliative care for many years. I trained initially in theology in Edinburgh and then did medicine, trained as a GP, and then worked abroad in Nepal for about 8 years, came back and completed training in palliative care. And I've been in palliative care since then and have been involved in Project ECHO since 2013 as well.
And what really drew you to palliative care? You started out as a generalist and, practiced for quite a while in Nepal. And then how did you get drawn into this world of palliative care?
Two big things. One, my mum died when I was 9, and her death had a huge impact on me. I think quite a lot of people in palliative care have had an early death. And the importance of trying to do something to help other people going through that experience was really important. And then when I worked in Nepal, I saw an awful lot of patients coming to be seen by the white doctor up in the hills, traveling from across northern India, often with diseases that could not be treated and seeking medicines which couldn't work for them and spending resources that they didn't have and often then dying in buses or in trains. And so it made me realize just how important palliative care really was in all countries of the world, giving people the chance for a good death, not one far from their home, which was going to bankrupt their families.
And you talked a lot about seeing children even in these situations, and you brought an awareness of how many children in Nepal really needed palliative care. Tell us about the work you did.
I trained a little bit in peds as well. I would be a very rudimentary pediatrician, but we were really concerned in Nepal with the amount of children that were coming to our hospital with life-limiting conditions because we thought there should be many more. So we did a survey, a door-to-door survey just of our time. And the amazing result was that 1 in 3 of those households had a child with a significant disease or learning impact, or from deafness through to cerebral palsy to having had a fall and become paralyzed. Behind those closed doors, there were lots of children. And I think there was still a taboo about you didn't take your child out if it wasn't perfect. And there was a fear that if you did so, then it would impede the marriage chances of the other children and lots of issues around that. But worryingly, there were children and parents who were living kind of hidden lives, dealing with really difficult emotional and physical things.
Really speaks to that issue of those children being hidden. Hidden patients. And we know that 98% of the children who need palliative care are living in low and middle income countries. So it sounds like you really saw some of that need firsthand. You've spoken about yourself as really a generalist in education. What are some of the things you've done, and what's your philosophy about palliative care education?
I'm not sure that in many ways palliative care kind of needs a specialty in some respects, because there's too many people dying all the time. So we need everybody to be able to ensure that there's good quality care available for that once in a lifetime experience. So my goal is to encourage as many people as possible to have the basic skills and knowledge and confidence. So when we were in Nepal, I wrote some guidelines and then got involved in writing the Oxford Handbook and other books and a course called the European Certificate in Palliative Care, all about really trying to train generalists to provide good quality palliative care, because there will never, as I said, be enough specialists to deliver the care that's needed. When you're dying, do you actually want a new medical person or new nursing person to be parachuted in just at that point if your needs could not be met by a physician or a nurse that you knew and understood you? Because death is not a medical event. It's a life event.
And it even brings up for me the thought around community health workers who are members of your own community who can be trained up to provide some basic palliative care support.
I think coming from the West, when we went to Nepal, we thought, oh, we're going to teach Nepali people all sorts of stuff. And we ended up learning much more than we taught. But in terms of palliative care, there were aspects of Nepali palliative care which were way ahead anything that we could give in the West, where our families have been more fragmented and where care and responsibility taken by families. So I saw our role in palliative care in Nepal was one of very much learning what was being done and then seeing what could we do to complement that, as opposed to saying, stand back, we need to create a Western system of palliative care, because the compassion and the insight and the awareness was there. And if we could work together, then we could maybe make it even better.
And as you know, this week we're here at Meta Echo together. Many of our listeners might not have heard of Echo. Can you just tell us a bit about what is Echo? What's been your involvement with it over the past 10 years?
So ECHO stands for the Extension of Community Healthcare Outcomes. And it began when a hepatologist from Boston moved down to Albuquerque and discovered that people were dying of hepatitis C all across New Mexico who were living normal lives up in Boston. And why were they dying? Because the local doctors were nervous about using medicines that they weren't comfortable with. So people hadn't got the resources to travel in to Albuquerque to the one clinic where they could be helped. So Sanjeev Arora, he'd been using Skype at that point, and he thought, if I could just connect with these rural physicians, give them the support, then they would give the medicines. And within a couple of years, the viral load of people with hepatitis C in rural New Mexico had fallen to the same level right across the state as his specialist clinic in Albuquerque. And very quickly, that model of everyone a teacher, everyone a learner, supporting people online through the capacity to take on board new information, not just information, but the support to apply that information, knowing that you've got that backup with you. And that ECHO methodology is now being used right across the world. I think we're up to some 4 million people engaging in ECHO networks, including your excellent pediatric palliative care ECHO network. And it goes back to that desire that I've had all along to support generalists and to provide them with the energy and the information and knowledge. I don't think they need more energy. I think the knowledge to be able to work to their maximum capacity.
And I think we both love the philosophy of ECHO, of all teach, all learn, which it sounds like has been really your philosophy from early days, yeah. Really learning that in Nepal, perhaps. So that really is at the core of the ECHO message, I think, as well. What are some other lessons? You know, you've had a long career in palliative care. What would you say are some big lessons that you've had?
I think the biggest lesson is to listen to the patient. And if I'm going in to see a new patient, just to take 1 second and one breath before I go in, to get rid of the previous patient's thoughts and just to be able to be there and to listen and to think and to be with that person. Because if you can get that connection with them and understand a little bit about where they are coming from, then it makes it so much easier to be able to communicate what help you can and to do what you can. So I guess that's my biggest lesson is listening. And when I haven't listened, invariably it goes wrong.
I think we've all had that experience of not listening. You started out with a degree in theology, and there's been a Franciscan priest who's been very influential in your journey through palliative care. What are the insights he's brought?
His name is Richard Rohr, but there are two big things. One is thing that sticks in my head, and that is the only things that really change us in life, really change us, are suffering and love. Suffering and love. They're the things which make us actually change what we do, change our job, change our situation, make us do something different. And just when we think about pediatric palliative care and the birth of a child who's got a disability, that family is catapulted into that world of suffering and love. And it's transformational. And I've seen families broken by that, and I've seen families transformed by that. The other thing is that spirituality is kind of what we do with our pain. When bad things happen, do we look for other people to blame? Or can we somehow transform that pain and that difficulty into something positive? Again, I've seen families doing that. And I've seen families who are forever looking for other people to blame because it's just too painful for them to face up to what they're doing. So he's my Franciscan guru.
And that idea of what makes us have meaning from this experience, I think that ties in with what you're saying as well. And in palliative care, we often are coming alongside our patients. And you've spoken a lot about this. And this has kind of influenced your approach to caring for children who need palliative care. You're an advocate for generalist physicians, adult physicians to also provide care for children, if and when that's needed.
Absolutely. Our PANG guidelines, the guidelines which have got adult guidelines for right across the UK, as I said, 250,000 copies published, but we made sure that there was a section on pediatric palliative care, because if there's a child in need and there's a palliative care doctor there, it would be an awful shame if they didn't have access to good information to be able to help and support. I would never seek to displace someone who's trained in pediatric palliative care, but there's not enough of that very rare breed out there to look after the needs of the many, many children who have got particular problems to be faced. And again, I think through experience and through having a little bit of training, it's given me confidence to look after the common problems in children and to seek help when I need it, to face the big challenge, which for many of our colleagues is that, I'm not trained to do this. Oh dear, this is very specialist, particularly in terms of having conversations with parents and children and working in that different kind of dynamic. But if a child is in need and there isn't a specialist there, we need to do something, and we need to do something as well as we can.
It's a great message for our adult colleagues. And how would you respond, if people are really worried about the medications, they don't feel comfortable dosing for children? How did you kind of learn and deal with that yourself?
I wrote the guidelines alongside a pediatric palliative care doctor, and I had experience in Nepal of trying to manage pain and realizing that children soak up a lot more than what we anticipate. And pediatric palliative care is not the same as adult palliative care, but the principles are the same. So it's the same principles. Maybe that you start low and build it up, but you can do it safely using your adult palliative care principles.
I think that's a message we need to be spreading around the world. And that's part of what we're doing through our ECHO, is saying these are these core guiding principles. We can share them really broadly and discuss them and learn from them together. What do you see as the future for pediatric palliative care?
I think the future is so important, but it's a mixed future. It's a future of looking after the very complex children. Children have got very complex problems. So there's a direct clinical component, but there's also a huge educational component and support component, and providing that hand on the shoulder to allow generalists to provide that service and to be that backup and encouragement to allow children to be able to access help and support in their locality from people that they know.
Thank you, Max. That's been an inspiration to chat with you today and hear how you see the future of palliative care and pediatric palliative care as it moves around the globe. So thank you so much. And I hope you enjoy the rest of the Meta Echo conference that we're here for.
Thank you, Megan. You also are an inspiration, and your Echo is an inspiration. And seeing your friends and colleagues from Echoland meeting up in non-virtual environment at the Indian Association of Palliative Care, just let me see just how passionate your colleagues are. And I think the future is Echo, and the future is pediatric palliative care.
Thank you, Max.